Mood disorders. Module 3. Bipolar disorder. Mania, hypomania, and nursing priorities. Bipolar disorder is a chronic mood disorder characterized by episodes of mania or hypomania alternating with periods of depression. Unlike major depressive disorder, bipolar disorder includes elevated mood states that may become dangerous due to impulsivity, poor judgment, and decreased need for sleep. Nursing care focuses on safety, structure, stabilization, and long-term relapse prevention. Bipolar I disorder requires at least one full manic episode. Mania causes marked impairment in functioning, may require hospitalization, and can include psychotic features. Bipolar II disorder involves hypomania and major depressive episodes. Hypomania is less severe than mania and does not cause significant functional impairment, but it still represents abnormal mood elevation. Mania includes elevated or irritable mood, grandiosity, decreased need for sleep, pressured speech, flight of ideas, distractibility, increased goal-directed activity, risky behaviors such as impulsive spending or sexual indiscretions. Symptoms must last at least 1 week or require hospitalization. During mania, assess sleep patterns, impulse control, risk-taking behaviors, financial or legal consequences, substance use, psychosis, suicide risk during mood transitions. Mania increases risk for injury and vulnerability to exploitation. Safety is always the priority. Mixed features occur when symptoms of mania and depression are present at the same time. A patient may have high energy and agitation while also feeling hopeless or suicidal. This combination significantly increases suicide risk because the patient has depressive despair combined with manic energy. Immediate safety assessment is essential. Rapid cycling is defined as 4 or more mood episodes within a 12-month period. Episodes may include mania, hypomania, or depression. Rapid cycling is associated with greater illness severity and requires close monitoring and consistent follow-up. Cyclothymic disorder involves chronic mood instability lasting at least 2 years. Individuals experience hypomanic symptoms and depressive symptoms that do not meet full criteria for major episodes. Mood fluctuations are persistent but less severe. Cyclothymia may progress into bipolar I or II over time. Effective communication with a patient experiencing acute mania is both essential and challenging. When a patient is hyperverbal, pressured in speech, or easily distracted, long explanations or emotional reactions from staff can escalate stimulation and disorganization. Nurses must use a firm, calm, and consistent approach with short, clear, and concrete statements. Limit setting should be direct but non-punitive, and redirection should occur early before behaviors intensify. Maintaining neutrality helps prevent power struggles, while team consistency reduces splitting and manipulation. Therapeutic communication during mania is less about processing feelings in the moment and more about providing structure, safety, and stabilization through controlled, intentional interactions. Use short, simple instructions. Avoid power struggles. Offer high-calorie finger foods if the patient cannot sit long enough to eat. Encourage rest periods. Reinforce sleep routine and sleep hygiene. Common nursing diagnoses include risk for injury, disturbed thought processes, impaired social interaction, sleep deprivation, imbalanced nutrition, and non-adherence to medication. Physical exhaustion is a real risk during mania. Individuals with bipolar disorder spend more time in depressive episodes than manic episodes. Suicide risk is highest during depressive phases and during transitions between mood states. Mixed features and impulsivity further increase risk. Always assess for hopelessness, access to means, and intent. In severe manic episodes, particularly in bipolar I disorder, patients may enter a psychotic state. Psychotic features during mania most commonly present as grandiose delusions, such as believing they possess special powers, divine status, extraordinary wealth, or unique abilities. These delusions are often mood congruent and reflect the inflated self-esteem seen in mania. At times, individuals may also experience hallucinations, though these are less common than delusional thinking. In rare but serious cases, extreme mania can progress to a catatonic state, characterized by motor rigidity, mutism, or purposeless agitation. The presence of psychosis indicates greater severity, requires urgent stabilization, and significantly increases safety risks. Bipolar disorder is a chronic condition requiring long-term treatment. Medication adherence is critical, even when the patient feels well. Stopping medication during stable periods is a common cause of relapse. Teach patients to recognize early warning signs of mania, such as reduced sleep, increased energy, impulsive decisions, or racing thoughts. Families should monitor behavioral changes and support consistent routines. Frequent follow-up and ongoing monitoring reduce hospitalization and suicide risk. Mood stabilizers and antipsychotics are commonly used in bipolar disorder management. For detailed coverage of medication mechanisms, monitoring, side effects, and toxicity, refer to the Psychopharm video series. This module focuses on assessment, safety, and nursing management. If a manic patient is pacing, intrusive, and not sleeping, the priority is not therapy discussion. The priority is environmental structure and safety. Stabilize first, process later. In this module, we reviewed bipolar 1 and 2, manic symptoms, mixed features, rapid cycling, cyclothymia, nursing diagnoses, acute management, and suicide risk. We also covered patient and family education. Bipolar disorder requires structured, consistent, safety-focused nursing care and long-term adherence to treatment.